PD-L1 testing is a bit of a minefield at the moment. It's probably the best and most reproducible biomarker we have in terms of predicting likelihood of benefit from therapy with either a PD-1 or a PD-L1 inhibitor. The problem is that there are a number of different assays that are used to test for PD-L1, and that depends upon essentially how that assay is being done to predict for receiving treatment with the different immune checkpoint inhibitors. So the main immune checkpoint inhibitors, for instance, pembrolizumab, nivolumab, atezolizumab, durvalumab, will use different assays based on different antibodies to assess PD-L1. And then the scoring system is based either on staining of tumor cells or staining of tumor cells and immune cells or just immune cells. And then the thresholds set for positivity are different depending upon the different antibodies and, to add further level of complexity, depending upon the different tumor type. So for instance, in head and neck cancer, which is the area in which I work, we have a situation where in the second line setting, pembrolizumab is approved in the United States without the need for a PD-L1 biomarker, whereas the EMA European approval is based around a tumor staining, a TPS of greater than or equal to 50%. So there's a difference there. In the US, we now have approval for the use of pembrolizumab in the first line setting following the Keynote 048 data. And there the CPS has been set at greater than 1%. So now it's a combined proportion score of both tumor cells and immune cells, in contrast to the second line setting in Europe where the TPS is 50. So as you can see, there are some complexities around this, and we need to work through this as a community to see how we're going to get standardized assays.